Thank you very much. It's a pleasure to be here today for multiple reasons. I think that many issues that have been raised today again show that antimicrobial resistance is a cross-cutting issue. It's a multifaceted issue and cannot only be discussed only from a human side, but we've heard words today here like One Health, animals, environment, and I would like to start off my talk discussing the fact that we're all involved and we're all responsible for what's happening right now. I think also I'd like to say that based on what John Ryan just mentioned, all the council recommendations and the council conclusions and the surveys that have been done over the past 12 years, what ECDC has been doing also is really supporting what the recommendations have been put forth from those and also from previous work that have been done by many European stakeholders prior to that. What I'll highlight today, we're going to switch gears slightly and discuss also a little bit of epidemiology of antimicrobial resistance in the EU. These data are from 2011. They were the data that were published last year for European Antibiotic Awareness Day on the 18th of November, and the next data for 2012 will be published on the 15th of November, so I'm not really going to be able to present these here. I just wanted to say that I think, of course, it's very important for all of us here to support a full commitment of all societies involved, of all member states involved, of all international cooperation possible, and of course of TATFAR, which was such a strongly created commitment between the two continents. And I'm going to start today by bringing it down to more of a patient level, and to say that we also wanted to, at ECDC, look at the patients a little bit more too. And I would like you to look at just these two patients here. The one on the right had they both have multi-drug resistant bacteria. The one on the right illustrates something which is very interesting, a whole epidemiological component. Number one, he was quite healthy previously. He lived in Egypt, most likely was colonized with a carbapenemase-producing Enterobacteriaceum there. It was an OXA48. When he eventually got sick and was immunosuppressed due to chemotherapy for his acute leukemia, he then developed a bloodstream infection with this bacterium. It was very difficult to treat him. It took a long time to actually identify the organism. He was given the wrong antibiotics for a while, and as John Rex highlighted previously, timing and timely administration of the correct antibiotic are really important. I think these two cases highlight, because the one on the left actually was a community-acquired E. coli, which was very resistant, and it was an ESBL-producing organism, and the one on the right, possibly also community-acquired, but maybe also hospital. And I think here, because the topic of my title is the use of my talk is the community and hospital settings, I'd like to highlight the importance of the fact that it's not only in one sector, but it's all over. Risk factors for overuse of antibiotics or for the development of resistance are, of course, antibiotic use, but also antibiotic use and antibiotic pressure, we mustn't forget, are drivers for the spread of resistant organisms as well. And we must not forget, and I'll highlight it here a little bit, that I think we can't talk about antibiotic stewardship or antibiotic use without discussing appropriate infection control in hospitals to prevent and to work together as a multifaceted component. The next one is, you may have seen the slide before, it is from the 2009 publication from the EMA and ECDC, Bacterial Challenge Time to React, where it's highlighted, again, the gap of the antibiotics available in the pipeline. It's again identified that mostly for gram-negatives, there are no antibiotics for which to treat many patients. And at this point in time, and we'll see later on in the epidemiology, we may not have any antibiotics to treat certain patients who are resistant, who have bacteria resistant to everything. And we see here the importance of why we're even here today, I think. We're looking at the attributable deaths from infections with multi-drug resistant bacteria, 25,000 per year approximately. These These are underestimates, most probably due to inherent bias and surveillance issues. And we see, of course, the economic burden, and we see extra hospital costs and productivity losses. Now, these data have been highlighted in multiple data from studies in the literature as well. And just some better news. I will start with Staphylococcus aureus. This is the epidemiology of Staph aureus in the EU in 2011. Data from last year, 2012, from EARSnet, showing you that there was a change and probably a decrease in a few countries in Europe in the prevalence of Staph aureus infections. These are, of course, invasive infections, so mostly bloodstream infections, and these mostly are in countries that had decided to implement very strong infection control measures in their hospitals, and also most probably prudent use of antibiotics and increased stewardship measures. But then we look at E. coli and the percentage of invasive isolates resistant to third-generation cephalosporins, most of which were most probably ESBL producers. And I want to highlight this slide, and not because in the community we had an increase of ESBL producing in the community, which is very important due to CTXM15, and also in the hospitals as well. And the problem is that because if you look on the right, 2011, in most countries there's been a significant increase, and this has been, of course, due to the spread of these resistant bacteria, but also to patient mobility. I mean, I think patient mobility is extremely important to highlight here in view of the cross-border directive, and also because of patient transfers. And just to show you this slide first, and the importance of the fact that ESBLs have been increasing also means that carbapenem consumption will increase, because those are the drugs of choice for ESBL producing organisms. And we see here that between 2007 and 2010, and this is mostly in hospitals, these data are from hospitals, we see that there's been an increase in carbapenem consumption. And again, I think that is also multifactorial. You know, I think physicians are probably afraid that when they receive a patient, they don't know what they have. They may immediately go to something which is more broad spectrum, more last line, and but perhaps they don't ever scale down. And so we see this increase in consumption, and we can go back and just see that was in hospitals. But I want you to look at this slide. These are data, again, from 2010, published last year in 2012, and these are mostly in the community. These data are from ESAC-Net, which is now coordinated by ECDC, showing that consumption of antibiotics in the community. Also in certain areas, we see that there is sort of a north-south, in a way, difference. And we know that between countries, for instance, Estonia, which had the lowest consumption in Europe, and Greece, which had the highest consumption in Europe, there was a 3.5-fold difference. And I would like to just point out, I didn't include the slide here because there wasn't enough time, but there was a Eurobarometer in 2002 and one in 2009, which showed, both of them, that although over-the-counter sales of antibiotics without prescription should really not be occurring in the EU, we do still see that in many countries this does occur, and although it's not in an enormous percentage of, but it still does occur, and there were no tremendously significant differences between the two Eurobarometers. I think that the new Eurobarometer will be coming out on the 15th of November, along with all the other data from also from ECDC, so that should be something that you should look forward to. And just the last slide on the epidemiology, these are again, surveillance data from EARSnet on Klebsiella pneumonia, and these are invasive isolates resistant to carbapenems. These are not carbapenem maize producing, because we don't currently look at that. But although you see that only a few countries are in red on the bottom of the slide, in 2011 you see that in 2008 there was only one. And the problem is that these do exist actually in all countries, and these are the limitations of a surveillance system. And although the Council recommendation strongly suggested that surveillance needs to be in place, I think surveillance is getting better, but the problem is it's always going to be the tip of the iceberg, as you see here, because in the community you'll have bacteria that are never isolated, that are, and even the ones in the hospitals. It depends, of course, on the culturability of the of the hospital, of resources, awareness, etc. I'd like to show this really interesting slide. Last year, so again, to support the Council recommendations and also to be able to move forward a little bit with surveillance, 30 countries participated in a very, very large point prevalence survey in Europe, coordinated by ECDC. And this was to look at prevalence of antimicrobial use in acute care hospitals only, and also to look at healthcare-associated infections, but also they looked at antimicrobial resistance in those healthcare-associated infections, so to also see that those two are not dissociated. And also some other 3 indicators were integrated, surveillance indicators in these. And you can see the differences. Number one, the differences, this is Europe, and you see that in, there's again a north-south slightly distinction in antibiotic use. I think that just wanted to bring up the 3 indicators that were included here. One was alcohol consumption, so the measurement of alcohol consumption for as a surrogate marker for hand hygiene in hospitals. The other one was measuring the number of full-time equivalents of infection control practitioners, so how many people in the hospital were really involved in infection control and had been given this position, and then also how many single rooms were available. Now, some really good data came back from those and that will be really good to be able to feed it back to countries and for countries to use it for their own purposes. Let me just remind you, of course, that we work very closely together with member states to be able to support them to be able to implement or develop guidance to be able to support their needs. In the ECDC point prevalence survey, I wanted to bring up the issue of antimicrobial use again and to show you that 1 in 3 patients on any given day had received at least 1 dose of an antibiotic. And also the fact is that if you look at this slide, so antimicrobial resistance, you'll see that these the pie charts in blue are those that portion of those bacteria. For instance, this is an E. coli, and you see that 23% of those are resistant to carbapenems, and so are all the other ones in blue. And I think that's very significant to show you that antimicrobial resistance is not just a theoretical thing, and it's not dissociated from the healthcare-associated infections. And the more infections you have that need to be treated, the more antibiotics you use. And so the drivers are many, of course. This is multifaceted, but also don't forget that it needs to be tackled from many places. This is also a very interesting slide. We see that 16%, if this in green, this the section on the pie chart, 16% of these antibiotics are used for surgical prophylaxis. So that is the antibiotics given to patients before they go to surgery when it's indicated. And so that's a big point of interest because there are multiple guidelines that come out. It's part of antibiotic stewardship in general. And we see that out of those 16%, if you see the smaller chart on the right, you see that 25% got 1 dose, which is sort of the appropriate, the recommended 1 dose or no more than 24 hours. And you see that 16% got 1 day, and then 59%, and this is probably an underestimation, got over 1 day, which is something that we and the literature does not recommend. And this again is a driver of antibiotic overuse in hospitals. So I just wanted to say we need to look at ways to decrease antibiotic use. Of course, if you look at the epidemiology of antimicrobial resistance, in some countries it's so high that it becomes a vicious cycle. Of course, it needs again to be stated that multifaceted measures need to be implemented. Infection control needs to be strictly implemented to be able to bring down the spread and to be able to eventually decrease the use. But also, what can we do in the community? So European Antibiotic Awareness Day had targeted the community for 2 years in a row, primary care physicians and also patients. But also in hospitals, stewardship is a big issue, and ECDC will be developing, so there is currently a group in Europe is developing antibiotic stewardship guidance, and we will be continuing that and also developing indicators. But what to do about the overall problem, I think that I've heard many times that people think that people should follow guidelines or treatment guidelines, and I've just wanted to show you how difficult it is and how complex the situation can be in many member states, since many member states have different healthcare infrastructure. And this is just the results of a systematic review from Prohibit, which looked at guidelines, and these are guidelines for prevention, but I just wanted to show you because it's quite representative, and these data also came out a little bit from the Council conclusions and the survey for the Council recommendation of 2009 on patient safety. If you see that they looked at 5 different healthcare-associated infections, one of which was Clostridium difficile, and we know that that is an indicator for antibiotic use in general. And if you have lower rates of Clostridium difficile infections, you can use that as an indicator for a hospital's antibiotic use. But if you see, there were 101 national guidelines in total for prevention, and 8 countries out of the 34 that were looked at actually had no guidelines. Only 14 out of the 34 had guidelines for all 5 of them. If you see that the strength of recommendations, so the evidence-based and the evidence sort of analysis of this is reported only in 56%, so questionable evidence, or at least it's not implicitly displayed. And then also ECDC had guidance, and this is kind of indicative, I think, that ECDC had published guidance in 2008 for C. diff, and and that was in 2008. However, currently in Europe, 16 different guidelines were still found for C. diff, with variable recommendations, including not using soap and water for cleaning hands. So just to conclude, what is ECDC doing? We work on, of course, I guess, the multifaceted approach to all this. And some of the key things that we've been working on, of course, is this Clostridium difficile prevention control, which has already been published. We had already published evidence-based risk assessment on the spread of carbapenemase-producing Enterobacteriaceae in 2011. We published this year, actually, evidence-based guidance on perioperative antibiotic prophylaxis. It's a technical report. It's on the internet. You can find it there. CITE is a really great systematic review and guidance that is currently in press, and those are 10 recommendations that every hospital needs to have to be able to start an infection control program. Next year, for 2014, we will develop common indicators for hospital antimicrobial stewardship programs. This is part of TATFAR as well, one of the recommendations from TATFAR, and a lot of these actually fall under TATFAR as well in some way. And another risk assessment and guidance will be prepared for next year, focusing on patient transfer. So how do we work together? Again, ECDC is very active in supporting member states and developing risk assessments for the needs that come up, especially, and making sure that everything is evidence-based. And to support the dissemination of these at any time we can, and to make sure that these go out into the community. We're planning to have a repository of existing guidelines on the ECDC website for next year, so that people can refer to those. And then I think what's really important is to develop and integrate and link more indicators into surveillance protocols, like, for instance, preoperative antibiotic prophylaxis, or anything else that has to do with antibiotic use as well. And please don't forget, European Antibiotic Awareness Day is on the 18th of November. And I'd like to thank everyone who was key in these data. Thank you.